Ladies and gentlemen, if you look at this photograph of optic nerve head in primary angle closure glaucoma, it's chronic form, and you can't find any differences with optic nerve head in primary open angle glaucoma. We know that the appearance of optic nerve head much depends on the mechanisms that have caused to its damage, and that is why, for example, the focal type of excavation is very typical for primary open angle glaucoma, and especially for normal tension glaucoma. While in myopic eyes, we can very often see the tilted disc with very large peripapillary atrophy, as well as in the senile sclerotic type of excavation that is rather rare, and the generalized enlargement of cup. This type of excavation is very common in glaucoma with a high IOP. And it is characterized by the large cup area and very thin rim area, as well as with the peripapillary atrophy of retinal nerve fibers. One may assume that this type of excavation is very suitable for primary angle closure glaucoma. Interestingly, that there are only few publications in literature on this issue, and all these papers were published many years ago. The authors have noticed the lower prevalence of peripapillary atrophy in primary angle closure glaucoma compared to primary open angle glaucoma, and no local defects in the inferior temporal sector that we very often may see in the open angle glaucoma. Hence, the diffuse loss of visual fields is more typical for primary angle closure glaucoma. And if we find the central visual fields defects, they are usually more severe. It is worth noting that the optic nerve head in chronic angle closure glaucoma is more damaged compared to the acute angle closure glaucoma. Moreover, very often after the acute attack, one can see the normal optic nerve head as well as the normal visual field. It means that the duration of pressure of IOP is more harmful for optic nerve head than the level of IOP itself in acute angle closure glaucoma. Interestingly, that the attention to optic nerve head in primary angle closure glaucoma has been increased due to the introduction of OCT and especially OCT angiography. The authors have reported about the significant dropout of vessel density in peripapillary retina after the acute attack of primary angle closure compared to the contralateral unaffected eye. According to our recent data, the dropout of vessel density in the peripapillary retina in primary angle closure glaucoma is more pronounced compared to the age and stage-matched eyes with primary open angle glaucoma. And in both glaucoma forms, it is more pronounced than in the healthy eyes of patients with the same age. And what is more important, we have revealed that there is a very high correspondence between the vessel density in paraphobia and the lens thickness, but only in the primary angle closure glaucoma eyes. And we have studied the phakic eyes. This data is consistent with literature because some authors have reported recently that indeed in the chronic angle closure glaucoma there is a significant dropout of vessel density if the IOP is high compared to the normal IOP. In contrast to primary open angle glaucoma with the focal defects of capillaries, as we can usually see, in primary angle closure glaucoma, these defects are more diffuse and they are associated with the thinning of retinal nerve fibers. It is important to note that in comparison between primary open angle glaucoma and angle closure glaucoma in regard to OCT angiography data, there is the difference only in the peripapillary retina, but not in macula. explaining this data, the authors have assumed that this is due to the special blood flow to optic nerve that is derived also from the choroid. And we know that the choroidal blood flow much depends on IOP compared to the retinal microcirculation. It is interesting that when we have studied the predictors of glaucoma progression in both forms of glaucoma, and it was the prospective longitudinal study with a follow-up period of 6 years. We have detected that the progression of primary angle closure glaucoma is associated with a thick choroid, in contrast to primary open-angle glaucoma, which is associated with a thinner choroid. Moreover, if you look at these areas under the curves, you can see that the blood flow in vortex veins had the very high diagnostic accuracy in regard to the progression of primary angle closure glaucoma. And we know that the vortex veins are the main drainage for the choroid. So we have assumed that the lower blood flow in the vortex veins, the more disturbances in the choroidal outflow, and hence, as a result, the thicker choroid that is associated with glaucoma progression. And please pay attention that lens thickness also plays a role in the progression of primary angle closure glaucoma. When we have compared two groups of patients with progression and non-progression eyes in both glaucoma forms, we have noted that the rate of change, the rate of thinning of retinal nerve fibers and ganglion cells complex in primary angle closure glaucoma is 2 times higher than in primary open angle glaucoma. This data is consistent with the literature because we know that risk of blindness associated with primary angle closure glaucoma progression is 2 times higher than in primary open angle glaucoma. Though primary angle closure glaucoma is 3 times less common than primary open angle glaucoma, the number of people blind due to angle closure glaucoma is approximately the same. It means that the primary angle closure glaucoma is the main cause of the irreversible blindness, and we have to detect the rate of progression in this form of glaucoma as well. Of course, OCT is the best method for this purpose, and according to our data, we may reveal the progression of primary angle closure glaucoma in 39% of cases during 4 years. The follow-up period was 4 years in this our study. And when we combined two methods, structural and functional, so perimetry with OCT, this allows detecting the progression in more than half of eyes. Interestingly, that in contrast to primary open angle glaucoma, GCC, ganglion cells complex thinning, may better predict visual field deterioration than retinal nerve fibers, but only in primary angle closure glaucoma. That is confirmed by these Kaplan-Meier survival visual function survival curves. If you look at these graphs of the correspondence between the rate of structural and functional deterioration, you may notice that this correspondence is significant for the ganglion cells complex and insignificant for the retinal nerve fibers, but only in primary angle closure glaucoma. It means that we have to pay more attention to the ganglion cells layer in the monitoring of the primary angle closure glaucoma. As you can see in this clinical example, with the early stage of the disease, we may reveal the significant change, thinning of ganglion cells complex and insignificant change of retinal nerve fibers. By the way, the progression in this case is confirmed by perimeter data. And in the next clinical example, when we have followed the patients, we can see also the significant change of ganglion cells complex that is associated with the very fast dropout of vessel density in parafovea during a rather short period of time. despite any changes in visual fields and retinal nerve fibers. We know that the high IOP is the main risk factor of progression of glaucoma. And if you look at these areas under the curves in primary angle closure glaucoma and open angle glaucoma, you may see that the minimum IOP and maximum IOP had the higher diagnostic accuracy in predicting glaucoma progression in primary angle closure glaucoma, as well as the lens thickness. By the way, it means that the primary angle closure glaucoma is a more IOP-dependent condition than primary open angle glaucoma. And it means that we have to measure IOP despite the pandemic situation. And of course, we can't use the non-contact tonometry for this purpose because of the risk of virus spread. That is why we use transpalpable tonometry in our clinic, and more often we use the eye care tonometry with disposable probes. That is, of course, more recommended at present. According to literature, we remember about the very high short-term and long-term IOP fluctuation in the chronic primary angle closure glaucoma, despite the peripheral laser iridotomy. You can see that indeed this level is very high. And this raises the question, do primary angle closure glaucoma eyes need the hypotensive eye drops? According to the European guidance, we remember that medical treatment alone is contraindicated in patients with primary angle closure glaucoma. And LPI and peripheral iridoplasty are the initial methods for treatment on this condition. However, we know from literature that 1/3 of angles don't open following LPI. And the effect of argon laser peripheral iridoplasty is even less pronounced than in prostaglandin analogs. By the way, it was shown that prostaglandin analogs, for example, latanoprost, may decrease the IOP from 30 millimeters mercury at baseline to 19 millimeters mercury after 2 months, despite the 360 degrees of peripheral anterior synechiae completely covering the ciliary body of the eye. And it was confirmed in this study by the UVM and gonioscopy. The authors have assumed that latanoprost may increase the uvascleral outflow in the primary angle closure glaucoma through the posterior chamber between the iris and lens and through the peripheral iris itself and the iris root. That is why we should keep in mind that other prostaglandin analogs are also recommended for this purpose, of course, only after LPI, and some of them are strong, like bimatoprost. Anyway, we should remember about this class of medications. And I would like to attract your attention to brimonidine. Brimonidine was shown in one paper, and its fixed combination may cause the meiosis and a widening of the anterior chamber angle without changing the anterior chamber depth. Moreover, in contrast to pilocarpine, brimonidine doesn't cause the contraction of ciliary muscles and a forward displacement of iris lens diaphragm. That is extremely important. So remember about these medications, as well about the preservative-free forms that are available nowadays. And what is about dorzolamide and brinzolamide? On the one hand, we know that these medications may improve the choroidal blood flow. On the other hand, we remember some papers about the contraindications, that this class of medication, the carbonic anhydrase, inhibitors may cause the ciliary choroidal effusion and ciliary body swelling and the displacement of iris diaphragm forward. So this is of course very dangerous because this is very often associated with some cataract situations, cataract extraction and other surgical situations. So it means that this class of medication is not recommended for the treatment of primary angle closure. What is about SLT? We remember from the recent study that SLT may become the initial therapy for primary open-angle glaucoma with a very high efficacy. On the other hand, once again, if you look at the European guidelines, the laser trabeculoplasty is not recommended. It is contraindicated in patients with primary angle closure and angle closure glaucoma. However, there are few publications in literature on SLT in the treatment of primary angle closure glaucoma after iridotomy. And the authors have reported about the rather high efficacy after 6 months after SLT. This efficacy is about 43%. Moreover, according to the Singapore randomized clinical trial, the efficacy of SLT in primary angle closure glaucoma is comparable with a prostaglandin analogs. And as you can see in these graphs, it is indeed comparable in some steps of the examination. Some authors believe that the efficacy of SLT might even increase by the 1 year after operation. However, according to our results of the prospective longitudinal study, when we compared primary angle closure glaucoma and open angle glaucoma, we have revealed that the efficacy of SLT drops dramatically within the first and the second years after the operation. And the efficacy depends not only on the baseline IOP and the number of hypotensive eye drops, but also on the anterior chamber depth in primary angle closure glaucoma, but not in primary open angle glaucoma. SLT may cause the damage to the corneal endothelium. Of course, this complication is very rare, but according to our data, if the corneal endothelium may be restored totally by the end of the first month after SLT, it may still persist in primary angle closure glaucoma even in 6 months after SLT, and we should keep in mind this data, of course. According to the multivariate linear regression analysis, not only the baseline endothelium cell count plays a role in regard to the damage of corneal endothelium in both glaucoma forms, as well as the age of patients, but the anterior chamber depth is very important in the primary angle closure glaucoma. So we have got some positive results, however, and according to our longitudinal prospective study with follow-up period of 5 years, SLT may improve the course of glaucoma in both forms of glaucoma, and it may even decrease the progression of primary open angle and angle closure glaucoma. As you can see in these survival curves, the results are better after the repeated SLT. So the question is SLT with or without medications recommended in angle closure disease? The answer is not clear until now because there is the lack of scientific data, of course. But we may assume that in some cases with a primary angle closure with IOP lower than 30 millimeters mercury after LPI, or even in primary angle closure and angle closure glaucoma with higher IOP after LPI, if the last one is not sufficient enough, and if PACG can't be applied for some reasons. We shall discuss, of course, the reasons. These reasons are very important. I hope that we will discuss them in the next presentations. But we should be careful about the anterior chamber depth, about the axial length, and the lens thickness, that is a very important issue. And of course, about the initial endothelium cells count in regard to SLT as the method of treatment of primary angle closure. In summary, patterns of damage to optic nerve head in chronic angle closure glaucoma are different compared to primary open angle glaucoma, as primary angle closure glaucoma is a more IOP-dependent disease with a faster rate of progression that, of course, is associated with a lens thickness. Prostaglandin analogs and brimonidine are the most preferable medications for chronic primary angle closure glaucoma treatment with insufficient LPI outcome. And SLT may be an effective adjunctive option in primary angle closure after LPI, unless refuse lens extraction, that is more important. That may reduce the rate of progression. However, the results depend on the pre-treatment anterior chamber depth. Thank you very much for your attention. This is our clinic, this is my team, and I would like to invite you to visit the site of our International Symposium, Controversies in Glaucoma, where you can see all the materials of the previous symposiums as well. Thank you very much.